Welcome, everyone, to the 10th episode of the POCUS Journal podcast. My name is Jamie Galen. It's an absolute privilege to be here today for many reasons, to be recording the 10th episode of our very popular podcast. It's really exciting to have two colleagues from New York City here to talk about a lot of things, including their research article. The research article that we're going to be talking about today is easy to find at POCUSjournal.com. The full issue is available for free. As I'm sure our listeners know, POCUS Journal is the world's leading free open access POCUS specific journal, and it has all articles available for free as individual downloads, but also the entire issue. And this research study we're going to be talking about is on page 109. That's in the November 2024 issue. That's volume 9, issue 2. And we are really fortunate to have the first and senior author of the study available today on our podcast. The article is Knowledge and Confidence Among 5 Cohorts of Faculty Learners in a Point-of-Care Ultrasound Program, Factors Defining Learner Success. So without further ado, I'll have the first and senior author introduce themselves. We always ask our guests to tell us, of course, their first kiss with point-of-care ultrasound, maybe there's a case or a time they remember when they fell in love with POCUS. So, Mike, we'll start with you.
Hi, thanks for having me, Jamie. So I'm Mike Janjigian. I'm a associate professor at NYU and associate chief of medicine at Bellevue, and I run now that Harald has left, I run the POCUS course for internal medicine here at NYU. So yeah, Harald was my first mentor and teacher, and I would say my first kiss, I'm going to give maybe 2 quick answers. One was before I took the course, I needed to do a paracentesis, and I was unable to because I didn't know how to use ultrasound. My resident didn't know how to use ultrasound, and by then it was pretty much standard of care. And I had this moment of like personal identity crisis where I couldn't do my own procedure. And so Harald was offering this course, and I took it, and it's totally changed my life. I would say actually using POCUS, probably that first kiss moment was doing a rapid response on psychiatry where we just didn't know what was going on, and just out of desperation, we just put the probe on the guy's belly, and it showed a massive bladder, urinary retention, and we drained his bladder, and he got better like immediately. So that was very impactful for me, and I use that anecdote all the time.
Thank you so much. Harald, tell us about you.
Yeah, hi. So thanks, Jamie, for having me on. First, my name is Harald Sauthoff. I was at NYU for a very long time, professor of medicine there, and I recently switched to Westchester Medical Center. I've been teaching POCUS for a long time, initially mostly associated with chest. As Mike mentioned, I started the POCUS program at NYU, and I'm now very much involved in getting POCUS up to speed here at Westchester Medical Center. So my first kiss with bedside ultrasound actually goes back a very long time. When I was a young whippersnapper, surgical resident in Germany, and we would staff the ED actually. And we'd get a lot of people with belly pain and fevers, and I scanned a lot of gallbladders and found a lot of problems with the gallbladder. And that's how I started. Then I came to the US, and then for 10 years, or 15 years, there was no POCUS. The machines were all locked up in the radiology suite. And then I was really excited when we finally got it out of there and got it into the ICU.
It's really great to hear your stories. In full disclosure, I've known both of you for many years, and I've taught in your courses. So but it's really great to hear that the origin tales. Let's jump right in. I want to first start so our listeners can hear about the course that has been studied in this research article. So I want to know how that course came into being. I think it's the iScan course, the Institutional Integrated Sonography course. Tell us the origin of that and a little bit of the details about who teaches and how you organize that.
So maybe I just talk quickly about like how it came about, the idea to start it, and then I'll let Mike talk about some of the details. But basically, the idea came about that, and I had been teaching ultrasound to the residents at NYU for quite some time, but I realized that we really needed a lot more teachers. And so that's what sort of generated the idea. And then Mike approached me also and others from the hospitalist service that there was interest. So that sort of kind of converged and was fortuitous. And then I created the first course. And Mike really jumped on and carried it on from there. Mike, do you want to talk about the details of the course, the course setup, and how it evolved over the years?
I've lost track of time. So I met you, Harald, in 2018 at Chest. So what years are we talking about when this course, when you say you started it or you were teaching residents, what time frame was that?
Well, I started teaching residents at NYU, I don't remember actually, a long time ago, right? As soon as we got a machine there, right, basically. Then I taught at Chest at the Essentials course for a long time, right? And the NYU course was basically modeled after the Chest Essentials course. And then Mike, I think we started the first course. The first course ran 2000. When exactly did it?
Yeah, it was like 2018.
2018.
Yeah, I remember those early days of trying to teach POCUS. I mean, I wasn't using POCUS at the time, but I remember efforts to teach like the residents cardiac and do like a couple procedural workshops. And we were trying to teach the students a little bit, and they all really, there was no traction. They all kind of really failed. And I remember that coming to the realization that if you don't teach the teachers, right, like how are the teachers going to supervise the residents and the students that are being taught? And I remember there was this paradigm of like, we have to teach the teachers and we have to teach them well to change the culture. I mean, fast forward, 6 years, there is a culture change, but that was the tipping point. So yeah, we can get into the course structure itself. I mean, really it was modeled. I mean, Harald developed this course based on the Chest model, which is, I think, why it's worked so well. It's a national standard that I think a lot of courses do use. And we've been able to implement it not only for this iScan course that you mentioned, but we've used it now for the residents and CME courses and things like that. It's a model that works very well, but it's a 2-day course. We upload content to Brightspace. So, Harald had recorded some videos. I had recorded some videos. There's some quizzes there. So the learners are directed there for pre-study. And then they come in for the 2-day course where we teach all the basic things: heart, lungs, abdominal organs, deep veins of the legs, and some procedural. And so they do a course of lectures, didactics, they do hands-on, and the majority of this is hands-on. That's really the most benefit from these courses, are the hands-on sessions. And there's also image reviews. So, over 2 days, 8 hours, it's intensive, but the learners are always just really engaged, and it's just really a lot of fun. But the learning comes afterwards. And so the question was really from the very beginning, like after these 2-day courses, how do we get people to actually adopt POCUS, become independent practitioners of POCUS? Because what we find is after a 2-day course, you've learned it well enough to practice, right? You're not proficient in POCUS after a 2-day course. You're good enough to go out there and try it and develop your skills.
It's great to hear about some of that structure there. For listeners who are inspired by what you're describing, essentially 6 years out of the initiation of a training course, they don't have, if you're at an institution where there isn't one, and they're listening and they think, oh, I want a faculty trained, as well. This is a good place to start. Any tips about how to actually operationalize a course, fund it, have models, having ultrasound equipment, the space? Can you tell us a little bit more about that?
Well, it's kind of really the challenge, right? You need machines, obviously, you need models. All this costs money. It depends on really where your institution stands, how many machines they have, and how they support you. There's a lot of industry support, often in terms of lending machines for these courses. So that's really something that is pretty valuable and easy to do usually. Funding of the models and the space is often really a problem, and that has to be done, depending on the institution. Right? So, I mean, at NYU, we established a pretty nice kind of way to do this. But now, as I'm at a new institution, I'm starting from scratch and realize the funding of this can be a challenge.
Yeah, what we've been looking at, and there's a lot of research on this, like there's people who do these courses, and then the majority don't go on to achieve independence in POCUS use. And I think that's been the challenge for every POCUS teacher, every hospitalist group in the country. It's really hard to get people to adopt a new skill. And there's a lot of reasons for that. But what we've seen is one of the biggest barriers to POCUS adoption in certain programs is just the availability of trained faculty. Right. And so that's one of the things we've been trying to correct here. And we've been very fortunate to have Harald, who is a national chess teacher, to kind of help build the course and be our initial mentor. And we were able to get this program running, but we've still found that getting faculty trained is the rate limiting step. So I think there's going to be those two things. If you don't have resources, you got to figure out a bare minimum to send your faculty to a 2-day course. And then they need access to a machine immediately, right? Availability. It's hard if you have to go to the ER or to the ICU every time you need to scan somebody. So that is a major limiting factor. There's a lot of ultra portable probes out there that people are starting to use. So that's definitely one limitation, but it's the human barrier, the teachers, that is the other barrier. And that's one of the things we tried to address actually in the study that we're going to talk about today.
Right. Really excited to jump into the study details. But before we do, one quick question. There's a paradox. If you don't have trained faculty and you want to train your faculty and you want to do a faculty training course, who do you get to help out with the training? How did you guys recruit faculty for the faculty training course?
First course was pretty exhausting. I gave all the lectures. So, I mean, you start off small, right? And then you need people like Mike Janjigian who jump in and take over. But at the beginning, it can be a challenge. You invite outside faculty. I mean, now as I'm here at a new institution, I invite my friends from NYU and everybody to help out. So you try to, if you want to start from scratch, you get your institution to support this. You take a CME course somewhere yourself, you practice, and then you convince your colleagues that it's a great thing to do, and then you invite friends to help you out with the teaching. That's kind of the model that works. An important part is institutional support, which I think is getting easier because most institutions really realize at this point that they have to have this and that they want to bring this out of the closet, which means they want proper training. They want documentation, they want eventually credentialing, etc. And institutions realize that needs financial support.
Excellent.
Yeah, I would say just to add to that, I remember the course that I took with Harald you had help from ED attendings, right? You can really I think every program has an ED program, right? In pulm crit care. And so maybe you don't have the benefit of pulling, colleagues from other institutions. But I've found that the ED and pulm crit care, even fellows, fourth-year ED residents are really interested in helping out. And so you just got to leverage the resources that you have.
Yeah, I think we mentioned this earlier, but the learners in this course tend to be internal medicine hospitalists, but the experience and what you learn from this extends to a lot of different other specialties, whether it be pediatric critical care or nephrology or whoever is trying to start a POCUS program. So jumping right in, I want to know how you decided to do a study of a course, what the gap was at the time that made you put in that extra effort. I mean, here you are teaching a lot of faculty, I'm sure also doing UME and GME training at the same time, a lot going on. How did you conceive of a study design or start to collect data, and any advice you have for listeners who may be in the same boat?
Mike, you could talk about the details, just about the motivation for this again, right? I mean, I think one of the biggest problems all POCUS teachers run into, you run a course and then only like a relatively small percentage really becomes proficient afterwards. And we were really motivated by looking into this, why that is and what the barriers are and what helps. So that was sort of the motivation for the study. Because it's a problem, like all courses in the country, everybody has that same problem. You teach a course, everybody is excited. At the end of the course, everybody loved it. Everybody improved their knowledge. And then 70% go home and don't really practice it and don't become proficient. So that was the motivation for the study. Mike, maybe you want to comment on the details.
Yeah, we had some ambitious goals from the beginning. We wanted to see, because we had partnered with Butterfly early on, because we needed access to probes, and they needed access to faculty to use the probes and try them out. So we had wanted to have everybody upload every clip that they were doing, and we could look at learning curves for how quickly they were learning every study. It turns out that we learned pretty early that it is hard to get people to upload clips, and that is a recurring theme. But on the background of that, we were collecting just a lot of data. We made everyone do a pretest. We were doing, we were doing satisfaction surveys of the learners. We just had a lot of data. Luckily, at our program, we have a very deep research group through our primary care, and we partnered very closely with them. And so they provided a lot of support with the data management and the data analysis. So that first group from 2018, it wasn't a huge group. We had like 24 learners for the hospitalists, and ultimately 19 of them were able to complete all of the assessments that we wanted them to do. So we did have pretty comprehensive data there, and some of the outcomes there, if you want to get into that, we found really helpful with how to move the program forward year by year.
Excellent. That's really helpful. I think just to jump right in, let's talk about what you did in the study, what you measured, the types of surveys you did.
Yeah, so we did. So we had everyone do this knowledge test. So Harald wrote this 26-item knowledge test, which looked at things like just basic ultrasound knowledge, some physics, but image reviews, but also a lot of clinical integration questions. And so we had everybody do this test like immediately before the course, immediately after the course. But we also tested them a year later. We wanted to look for educational delay. We also looked at things like their confidence in using ultrasound, of acquiring images, of interpreting images. And so what we found is, of like no surprise, after a 2-day course, people did better on a test, right? Their confidence went up. So that was not surprising. What we found really interesting, though, was we compared immediately after the course to 1 year later. And we found that their knowledge scores had gone from 85% to 81%, which went down. But after a year after a course, we were actually very encouraged that people maintained most of their knowledge. We also did a hands-on test. This is like a very labor-intensive test. It's like one-on-one with a standardized patient. And it can take 20 minutes sometimes to run through this test. But we did it for all of these 19 learners. And we found that immediately after the course, they were scoring like a 75%. And a year later, all of these 19 learners scored a 74%. So their hands-on skills did not pay even a year later. So we were very encouraged that the longitudinal part of the curriculum was also effective. And so then we looked to see like which parts of that curriculum correlated with success. And so then
before we get there, Mike, I'm so sorry. Let me ask you really quick. That seems like a really big deal to do hands-on skill assessment in adults. Like I say adults, I mean, forgive me, you and me and GME are also adults. I mean, for attendings, how did you get them back on it for a hands-on skill assessment within a year later?
These are all people in our family here, right? This was the learners were over a few different hospitals, but this was our hospitalist group. And I think they were very appreciative of the education that we were giving them. They all really loved taking the course, and they all wanted to learn more, even if they were not using it. They certainly felt like indebted to us for providing the education. So they were happy to come back and do the test.
Yeah, I just want to highlight that as a strength of the study, because a lot of POCUS, educational studies, studies of curriculum and courses has really relies on self-report, which, I think the confidence assessment, self-assessment, is important data, but having a hands-on skill assessment is a unique feature of the study. But go on, I interrupted you.
And this is not something that's easily done. It's like it's faculty time on both sides, SP time. You're in the sim center. It's there's a monetary cost as well as a time cost to it. So we did this for this 2018 cohort study. We have not done it since because it's just too labor intensive. But it was useful though to have it at least robustly done this one time.
And I interrupted
Also,
you.
as you know, I mean, you're pointing out all the difficulties, but it's also these hands-on tests. There are problems with that as well, right? Unless it's all done by the same tester, there's differences, and how you test to standardize it is not that easy. So if you look at data from hands-on tests, it's not perfect either.
Yeah, I was thinking as you were saying that the hands-on test is in a sim center with a model who may have very good windows, for instance, that may not be real life applicable. So there is an issue about generalizability from that. But still, I think it's a strength that you guys were able to include that early on. Mike, you were saying further about some of the methods you were using from 2018.
Yeah, so using this hands-on test as like our gold standard, say, even though as Harald mentioned, it is flawed. What we found though that participants that uploaded clips, and we could track them using the Butterfly, the cloud, is that participants who uploaded clips had the highest correlation with success, right? Followed by actually the knowledge score correlated well with the hands-on test. That was a useful finding as well. And then kind of less so, but still correlative were, attending our conferences and going to the hands-on teaching sessions. But ultimately, it was the clip uploading that was the most powerful correlate with success.
So my take home from that is if you use it, you don't lose it.
That's right.
Okay. And the clip uploading is the portfolio, anonymous images for the portfolio for certificate of completion.
Well, it led to the portfolio, but at the time, since we had the Butterfly devices, we could just tell who was uploading clips. So it actually these could have been good or bad clips. It didn't matter. It was just the number of clips uploaded by user.
Got it. So that was one of the key findings, was that using the Butterfly handheld uploading clips led to longitudinal skill retention.
Yes.
Got it. What else did you find? What are some other key take-home points?
Well, for that study, that was honestly our main takeaway, is that the 2-day course was effective, the 1-year longitudinal curriculum was effective, and the most important component of that was the learners, right, self-motivation to actually upload clips. So it helped us as we were moving forward with the course to really encourage people to upload clips, not just tell them to scan and give them machines, but to get them to actually upload clips. And then that led us to then say also, well, we don't want you just to like do clips. We want you to, prepare a portfolio. So we said, let's model it after the Society of Hospital Medicine portfolio and certificate of completion. And that will model our own certificate of completion based on that model as well. And so ever since then, we've been encouraging our faculty to complete this portfolio.
You mentioned a handheld ultrasound, one of the available devices. Did you find that availability of a handheld, sort of made it easier for folks to continue to upload clips? I guess one of the barriers that is faced, there's so many barriers, but one of them is, I'm scanning, but I'm not really taking the time to save clips or export them because it requires a USB, and my dog ate my homework and my USB isn't working, and excuses. Like, what are some other sort of even anecdotal insights you have about those barriers of getting people to upload clips? Like who uploads clips?
It is funny you said that, because literally a dog ate one of my faculty's USB drives with his portfolio on it.
That is the ultimate excuse.
But at the end, Jamie, it is true that like if you have a network where you can upload, makes it a little easier. But at the end, people have to be motivated to bring an ultrasound device to the patient's bedside and scan. That is the key thing. And they got to get into the habit of doing this. And that's really the hard part. Uploading into a network and ease of that does help. But the key point is really people have to change their habits, how to evaluate a patient, how to examine a patient. and bring their ultrasound device to rounds and answer quick questions. And that is kind of a change of habit, and habits are tough to change.
Yeah, since we're talking about this specific question, if we jump forward to the current paper, we actually did ask people that question, like their facilitators and their barriers. And we actually broke that down based on whether they had done a portfolio or not.
This is table 4, Mike. Is that right?
Table 4, yeah. And so I just think that since we're talking about the specific question,
walk us through it. Yeah.
Go ahead.
Walk us through it. Yeah, table.
Oh, yeah. So all of these learners, just to even talk about this portfolio, the facilitators and barriers questions, these learners are all in the same environment, basically. They might be at a different hospital, but there are people who had success and not success, even within a given environment. And so we asked basically all of these people who took this survey, which we'll get into the methods a little bit more, but, did you find access to an ultrasound machine to be a facilitator or a barrier? And people, even within the same hospital, like if they had done the portfolio, they found access to a machine was a facilitator, and nobody found it to be a barrier. The people in the same hospital with the same access to machines said that, actually having access to a machine was a barrier.
That I don't quite understand. So why would having access to a machine be a barrier to developing a portfolio?
Well, it was, they would say not having access.
Oh, I see.
A lot of people, but they said like not having access to a machine, was one of the reasons that, they did not, kind of complete their learning goals with POCUS.
I see.
But it's interesting because they all had the same access to the machine. I interpreted that as more of a psychological barrier.
Right, like it was on a different floor. It was I had to go plug it in. I had to take an extra step. Someone else was using it, that kind of thing.
Yeah, because we didn't want to presume when we asked these questions that it was definitely we didn't want to lead them that it was a barrier or a facilitator. So we asked it on this kind of dual-ended questionnaire. It was just interesting that people within the same hospital found that there was no problem to have machines, and other people in the same hospital said, oh yeah, there were no machines.
Right. Well, it's no coincidence the people that completed the portfolio found that not to be a barrier. What else from this is on page 114 in the November 2024 issue of POCUS Journal. It's at POCUSjournal.com. What else from table 4? It's a great result here. I think it's interesting to think about how portfolio completion. We were talking a lot about that. Anything else from that table?
Well, every POCUS study that they've ever surveyed anybody, they always report that time is the major barrier to learning POCUS, right? Or really to learning any new skill that you're trying to learn. But we did break this down by those who completed their portfolio and didn't. And, the question was time to practice. And, not surprisingly, those who completed the portfolio still said there wasn't as much time to practice. But those who did not complete it, there was overwhelming majority said that was the reason that they did not finish it. But again, these are people more or less with the same work schedule, right? With the same clinical load and the same clinical environment. And so some of it is just the perception of time. And some people who did the portfolio were actually able to, create time in their day, even if it was just 5 or 10 minutes, to the point that they were able to get that completed.
Right. It's so interesting because objectively, their peers. This isn't another institution. This is, someone in the same, hospitalist group or, department. Obviously the folks that were able to complete the portfolio found the time to practice, and those that didn't complete it felt one of their perceptions was that, oh, I don't have time for this. So,
right. And the time investment was worthwhile. And I think people who use POCUS enough realize the time spent actually is time saving, right? But until you develop your POCUS chops per se, right, you feel like it's just a time sink at first.
That's a really good point. It's really, really interesting to think that learning this skill can save you time once you get competent and proficient at using it. But that initially when you're doing it, it's I have to take 20 minutes to do a POCUS for DBT exam when I could take 1 minute to place an order to have someone else do it. But if it saves me time in other ways, and not to mention faster, better patient care, that it also is, it's worth the investment. It's interesting.
Yeah, we always talk about you got to get over the hump, right? Initially, you're do these studies, and it's just a snowstorm and it's completely useless. And you think, oh, well, this is a total waste of time. And that's until you get over the hump and you find your first tamponade or really interesting finding that saved maybe a patient's life or saved you a lot of time, actually. And then once you get over the hump and you realize how useful it can be and how it can speed up your diagnostic process, that's when people get into it and, all of a sudden find the time to do it.
Right. Once they have that first kiss and fall in love, then it's they stay with it once you're, in love with it. But to get there, one thing I'm curious, just hearing about your insights from this and thinking about the study, is there something that even anecdotally you can tell about a learner who's gonna in the intro course who's gonna be one of the ones who stays with it and completes a portfolio, and someone who's not? Is there anything you've learned either from the data, the survey, like again, because the attrition rate being so high, what factors are there that identify someone who's going to be successful?
I don't know, Harald, I'm curious your thoughts because you've been teaching this a lot longer than I have. I find it very hard to predict those people who are going to adopt and those who are not. We talk about like personal and professional identity, right? I had mentioned before that my impetus for taking the course and really wanting to learn it was not being able to do my own paracentesis, right? And I had a moment of like crisis. So my professional identity was one of like being an internist who should be able to do everything an internist does. And then I kind of like the rug was pulled out from under me, and it's hard. And so therefore I was highly motivated, but it's hard to predict out of our group of hospitalists who are all basically doing the same thing, which of those people are going to stick with it and which aren't. So I would love to know the correlation in advance, but I don't know what that's going to be.
Yeah, it's surprisingly difficult to tell. I mean, there are very few doing a course where you can tell they're not going to be into it and they're just not going to achieve proficiency, but that's a very small percentage usually. And then there's a surprisingly large group of people who are like really excited doing the course, and they're really into it doing the course. And at the end of the course, they say like, oh, this was so cool and I'm really going to use this. And then they don't. And I mean, we talked about things like, people's personality. There are early adapters and people who are more skeptical. But it's really hard to identify ahead of time people who are going to use it and who don't. I mean, there's other, like people say like, oh, years in practice or so, like people who are older and not going to adapt it as easily. That's not true either, I think. I mean, at least our data here, if you look at the years in practice and like how many people completed a portfolio and how many did not, there was no clear signal. And then in my personal experience also, I have some older colleagues who really got into it.
Yeah.
And so it's very hard to predict, actually. I wish I could really predict this and focus on the group who is going to succeed, but it's difficult.
Yeah. Well, I mean, I think that the importance of the study is identifying, the factors for that set a learner up for success, including the encouraging, new learners to scan. And I know that it seems like common sense, but I think that having the data that demonstrates that is a successful step, and that's a small step, but it's an important step to take for a new learner who, is at risk. I mean, a learner is at risk of attrition. They're at risk of falling off and not following through with it, having invested 2 days of their time and money in a course. And I think that's a key take home for me. Any other kind of key findings or results that you wanted to share from the study here?
Yeah, let me, if I could, maybe I'll just quickly summarize the methods of the study because we didn't actually get into it. So just to say, we started this course in 2018 and we've run it basically every year since then. Obviously, COVID changed things a little bit. And so what we wanted to know, like looking back over these 5 or 6 years, is like, where are they now? What are these faculty graduates of our POCUS course doing now? Are they using POCUS? Are they not? And again, what are the correlates? We did not do this hands-on test. It was too labor intensive, but we did do some assessments to be able to compare people kind of pre and post. So we had 89 faculty graduates. We surveyed them all, through Qualtrics. and we got 46 people to respond. And so what this study is describing that cohort of people who responded to this survey. So getting to your earlier point about like what was our other takeaway, what we found is the people who self-identified as having completed their portfolio, they were all teaching POCUS, right? So some were actually course directors, some are just teaching at our POCUS courses, and others were just teaching POCUS to their learners the way they would teach physical exam or any other skill. And so what we realized is like those go hand in hand, right? If you're using it, you're teaching it, especially if you're at a teaching institution. And so we've been really strongly encouraging immediate graduates from a course to start teaching right away, right? Low stakes teaching, I would say, right? So we have students on, POCUS elective and residents on elective, and the clerkship students need to learn it. So we're trying to get even early graduates from a course just out there teaching because they know it way better than the complete novices do. And it makes them up their game. It gets them really excited. They learn it more, and then incrementally they can teach more and more. We have them be what we call buddy teachers at our formal 2-day courses so they can partner with a more experienced teacher. It just gives them confidence as teachers. They learn teaching tips and tricks, and it progresses them through. So if that's one thing that I can recommend to people out there is as soon as you take the course, don't just try to start practice, but also try to get involved in whatever teaching, even if it's co-teaching. Do as much as you can as early as possible.
One thing I want to add is you're also fleshing out some of the other key findings. I think that it's really important to encourage junior faculty to admit when they don't know something, and actually learners find that I've observed this to be a strength that they see in their faculty, as opposed to say a weakness or something that's undermines the whole initiative. And what I mean is that if you take a 2-day course, like you're saying, and you teach what you know, which is maybe basic probe selection, probe manipulation terminology, basic exams like the bladder, but then find the limit of your knowledge as a faculty member, that when you admit to your trainees, it's a great question, I don't know either. Let me ask my someone who taught me. Let's look into it. We'll find the answer together. I think that collaboration is particularly exciting and rewarding in an educational environment where med students, residents feel comfortable learning alongside faculty, which is sort of different than historical hierarchical learning environments. I think that's one of the things that makes learning POCUS together so much fun, is it's a collaborative discovery. And I think that it's not knowing everything shouldn't be a reason you can't teach what you know.
Yeah, and I did want to make one other point about one of our major findings here is that, as I mentioned earlier, clip uploading was correlative with success, and we started pushing people to try to complete their image portfolio. I'll be honest, it's not that easy to do. It's 209 clips plus or minus. It's very comprehensive, and the clips are supposed to be of good quality. And so it's a labor to get it done. But what we found is on this survey, the participants who said that they completed their portfolio scored a 92% median on this knowledge test. And those who had not completed their portfolio scored a 68%. So 92% compared to 68%. That's a huge difference, right? Of kind of one item that can help differentiate people who know this information really well and those who don't know it as well. Portfolio completion also correlated with higher levels of confidence in image acquisition and image interpretation. And so we just found this, self-assessed portfolio completion was a really powerful finding, and is driving us even harder to try to get people to complete their portfolios.
Excellent. Well, I think it's really helpful to hear you break down the study in its design and the results and conclusions. Hearing from you two who authored the study, it's really helpful for our listeners who are probably going to want to take some of this advice back to their own training programs and implement these findings in their own courses. Before I let you both go, do you have any other advice for faculty who are out there trying to get courses, revise course structure, revise how they do their faculty training, and that's the crux of this is CME faculty training. Any other parting advice for them?
Maybe one last comment about testing at the end, because I think in the POCUS community, there's some kind of discussion about testing and how do you certify competence at the end or so. Just because there are a lot of people who still support hands-on testing, which, as we said, it has disadvantages and it's very labor intensive. And I think what's interesting is that our relatively short online test with 26 questions actually correlated really well with the hands-on test, with confidence, with completion of the portfolio, etc. So, I mean, this short online test actually seems to be a pretty good test. And for people who run programs, so I think that's kind of reassuring, because obviously that's very easy to administer. You make one good test that covers kind of all the areas, and it seems to be working pretty well.
So you're saying, if resources are limited, an online knowledge test, it might be sufficient. You don't need to have a hands-on, exam at the end or other types of proficiency exams.
I mean, by itself, maybe not enough, but if you have a test, an online test plus a portfolio, I think, in my opinion, that's good enough. I don't think a hands-on test adds that much to it. I know people disagree with that, but that's kind of my opinion based on the data we have, actually.
And my takeaway would be to encourage people to take a course, but you got to have access to a probe after the course. But just try to do 5 minutes a day, right? You might need to stay 5 minutes later, right? But just grab the machine, go see a patient, do something easy, a lung ultrasound, look for A lines, look for B lines. Just spend 5 or 10 minutes, a few times per week, and it'll make a huge difference. And that's really the way to do it.
Yeah. It's all about habit forming, right? So we teach our kids already, but if you bring a probe to when you see patients and answer one single question, hey, does this patient have pleural effusion? Yes or no? Right? It takes 2 minutes, and you get into the habit, you'll get good at it.
Yeah, the analogy I think of is with physical fitness. That everyone in January signs up to join a gym, and then certain very, very select few are still there in February. But it's doing 5 minutes of push-ups a day. It's just 5 minutes, but it's a barrier.
Yeah, 7-minute workout. That's right.
Exactly. Clearly, I don't do either of them. So, well, I really can't thank you both enough. This has been an absolute delight to meet with you on a podcast to talk about your really important work. And thank you both so much, both for what you've done for the POCUS community in this course, for your own faculty and for other learners. The study Knowledge and Confidence Among 5 Cohorts of Faculty Learners in POCUS program, Factors Defining Learner Success. That's on page 109 of the November 2024 POCUS Journal issue. It's at POCUSjournal.com. Thank you both again for your time, and see you soon.
Thank you.
Thank you.